Hi, today's lecture will focus on glucocorticoid remediable aldosteronism, which I will shorten as GRA, a rare inherited form of primary hyperaldosteronism caused by a gene alteration that results in aldosterone production being regulated by adrenocorticotropic hormone instead of the renin-angiotensin-aldosterone system axis, leading to hypertension, hypokalemia, and metabolic alkalosis. Now, understanding GRA is particularly important because it can be a hidden cause of hypertension in children or adults where secondary causes remain unidentified, emphasizing the need for accurate diagnosis and targeted treatment. So, join me and let's get started. Kindly hold on, this is not difficult. This slide will explain how an alteration of a gene can lead to a disorder like glucocorticoid remediable aldosteronism. So we have a promoter region here for angiotensin, and we also have a promoter region for adrenocorticotropic hormone. All right, as you can see, the promoter regions are paired with a coding region for aldosterone synthase gene, and the promoter region for adrenocorticotropic hormone is paired with the coding region for 11 beta hydroxylase gene. Simple as that. So this is the pathway where aldosterone is made from zona glomerulosa, and this is the pathway where cortisol is made from the zona fasciculator. The important thing I need you to know, that is a key point here, is the occurrence of unequal crossover between 11 beta hydroxylase gene and aldosterone synthase gene. I will explain. So remember this crossover, unequal pairing. What you can see is that the promoter region of ACTH has now fused with the coding region for aldosterone synthase gene. Okay, and this is where the problem lies. This is something we call a hybrid gene or a chimeric gene. This is the gene that is responsible for glucocorticoid remediable aldosteronism. In other words, we are now having ACTH controlling the formation of aldosterone instead of the renin-angiotensin aldosterone system axis. Now, ACTH is going to control the production of aldosterone not in the zona glomerulosa, but in the zona fasciculator of the cortex of the adrenal gland. On this slide, we will explore the clinical consequences stemming from the hybrid or the chimeric gene, okay, which we said causes aldosterone production to be regulated by ACTH in the zona fasciculator, where cortisol is normally produced instead of the usual control by the renin-angiotensin aldosterone axis through the zona glomerulosa. So this whole abnormal regulation leads to an increased aldosterone synthesis. There is more aldosterone formation, which in fact is driven by ACTH. Okay, more aldosterone will result in sodium water retention, which obviously would increase the blood pressure. Again, more sodium water retention would leave potassium no option than to leave the cells into the urine, causing hypokalemia. All right, the excess sodium water reabsorption would also suppress renin, which is consistent with primary hyperaldosteronism. So, in general, the renin angiotensin system would also be suppressed. In general, this highlights how the hybrid gene disrupts the normal control of aldosterone with significant effects on blood pressure regulation. Glucocorticoid remediable aldosteronism is an inherited condition passed down in an autosomal dominant pattern. This means individuals with the disorder have a 50% chance of passing it on to their biological offsprings. Symptoms including early onset resistant high blood pressure associated with a high risk for strokes, hypokalemia, and metabolic alkalosis, as well as arginine vasopressin resistance may all be seen. In fact, the clinical manifestation is the same as that of primary hyperaldosteronism. All right, the diagnostic approach for GRA is the same for primary hyperaldosteronism initially, but this should also include a genetic evaluation to identify its autosomal dominant inheritance. So initially, clinicians would assess plasma aldosterone concentration, which would be increased, and plasma renin activity, which would be suppressed. Okay, so the aldosterone renin ratio, ARR, would be expected to be greater than 20 is to 1. Now, to confirm the diagnosis of primary hyperaldosteronism, a provocative test such as using a normal saline, fludrocortisone, or salt tablets may be performed. Now, unlike in normal physiology, aldosterone levels in GRA fail to suppress. In other words, if you give somebody salt, you would expect the aldosterone levels to go down. But in this case, it would persist. Okay? A crucial step is the dexamethasone suppression test, which not only helps in increasing the likelihood of diagnosing GRA, but also explains why glucocorticoids are effective treatment. That is, dexamethasone suppresses ACTH, which is responsible now for driving the production of aldosterone. Okay, so complementing these assessments, genetic analysis can also pinpoint the specific mutation responsible for this condition. And it's important to note that prior to these investigations, you would have to correct the potassium levels. The management of this disorder often involves the use of exogenous glucocorticoids, such as dexamethasone or prednisone, okay, which helps suppress ACTH. So by suppressing ACTH levels, these medications effectively decrease the excessive production of aldosterone. Okay, this targeted approach helps in controlling blood pressure and alleviating symptoms, providing a beneficial treatment options for patients that are affected by this condition. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.